Natasha. I'm one of the PGY2s, and today I'm going to be talking about metabolic emergencies, specifically focusing on disease. Okay, so in my talk, I'm going to go over two interesting cases that focus on the extremes of calcium presentations in the emergency department. I'm going to briefly talk about calcium homeostasis, and then I'm going to focus on hypercalcemia, just what we kind of care about in the emergency department, and I'm going to do a quick recap. So let's get started. First case. So you're hanging out in CCT, you get a phone call, you're going to have a patient transferred to the facility. You're hanging out with Dr. McFarland, Dr. Doty, Dr. Zatachi, a couple years ago. And they tell you, in this transfer that you're getting a 30-year-old male that has a history of developmental delay, he has epilepsy, he's supposed to be on Dilantin, and he came into their facility with generalized tonic-clonic seizures. They did some blood work. They saw that he was hypocalcemic. Serum calcium was 4. They gave him an infusion of IV calcium. They gave him his home dose of Dilantin, and they got a CT head because they were a little worried that he wasn't returning to baseline. And you say, okay, so what's going on? Why are you transferring the patient here? And it's the future. Go back into the future, and they're able to show you pictures on an iPad or something, and you get this picture from them. And they say, we're transferring him to your facility because we're worried that this guy has a bleed. And so you say, okay, we have neurosurgery here, transfer the patient over. He gets to your ED, you reassess him, ABCs, whatever, he's stable. You're about to call neurosurgery, but Dr. Z, Dr. Doty, somebody says, wait a minute, this doesn't look like a bleed. And so you take another look at it, you call radiology, and they say, no, this is not a bleed. This is bilateral symmetric calcification of basal ganglia. And after further analysis, you admit this patient, they work him up, and they find that he has some congenital disorder that was actually never diagnosed that causes seizures because of hypocalcemia, as well as basal ganglia calcifications. And so this new diagnosis is made when this guy is 30 years old, and you save yourself a neurosurgical consult. Awesome. So second case, you're hanging out in TCT again, and the triage nurse comes over to you with an EKG. She says, hey, doc, I have this 31-year-old guy. He has hypertension, CKD, and he says he had some sort of thyroid or parathyroid issue and had a surgery last week. He's vomiting, he looks diaphoretic, he's kind of tired, he's confused a little bit, and you get this EKG. And you're looking at it and you wonder, is this 31-year-old having a STEMI? And so you see these ST elevations in leads V1 through V5. You look at the QTC, it's 415. And just before you think to call that code H or call that code heart, you say, let me get some blood work. You send off a shock panel, and his calcium level comes back at 17.8. This guy actually was at another facility, and he ended up going to the cath lab before his blood work came back. And they did cath him, they saw clean vessels, but then they got the calcium level back, and they treated his hypercalcemia, repeated EKG, and it went back to baseline. So he had an unnecessary cath intervention. So with that being said, let's talk about calcium emergencies, and quickly let's brush over the pathophysiology. So we know that calcium exists in our body in several forms. There's about 15% of it that's bound to anions. So that's like citrate and lactate and phosphate. And then we have 40% of it that's bound to albumin. And we have 45% that's free, which is the 45% that we care about because that's what our parathyroid hormones and our body kind of regulates and sees. Because of these different states that calcium is existing in, we know that we can see fluctuations in the calcium that we catch on our labs based on your level of albumin and also based on your anions. And so we know that you can have pseudo-hypocalcemia, for example, if you have low albumin, which is why we can correct that for albumin. I'm not going to put the formula here, but you can always do that if you're concerned about a calcium level that you get back. And so in terms of how it's regulated in the body, briefly, we have basically hormonal regulation of our calcium level. So homeostasis is kind of based on the parathyroid glands that releases parathyroid hormones, also vitamin D, and the GI tract and bone and kidneys play a role in this as well. So from the parathyroid hormone or the parathyroid gland, we know that sustained release and prolonged exposure can promote reabsorption of calcium from the bones. We also know that parathyroid hormone can act on the kidneys, and it actually helps us reabsorb calcium from the kidneys. It also stimulates the biologically active form of vitamin D. And then this vitamin D in the GI tract can allow us to reabsorb more calcium from the small intestine as well. And then in terms of the kind of the opposite of that effect, you get that with calcitonin, so it kind of tones down your calcium. And this basically acts on the kidneys to decrease your reabsorption of calcium, which allows you to excrete more calcium into the urine. So that's roughly as much as you probably need to know from the EM standpoint. And then in terms of why we need calcium anyway, who cares, right? Like this is like the one thing that I almost never look at unless like something happens there. And so calcium is actually super important. And we really need to just think about one thing, and that's action potentials. And so all of the things that need to contract, that need to release any kind of neurotransmitter, they're calcium-gated channels that regulate these processes. So in your brain, it's important for synaptic transition. In your skeletal muscle, it's important for skeletal contraction. And then your cardiac muscle, it's the influx of calcium ions is super important for sustaining your depolarization. So when you think about the side effects of having low or high calcium, always kind of think back to action potential and what you should expect to see in your patients. Okay, so for low calcium, when you're thinking about your patients that are at risk for hypocalcemia, use your clinical kind of history, use your eyeballs, and look at the patient and think about what the risk factors are. So renal failure. These patients have a lot of trouble with calcium reabsorption, with calcium and phosphate kind of metabolism in general. So whenever you see that patient with the AV fistula, you should, in the back of your head, be thinking about high and low calcium, these kind of patients. Patients are ETOH users that we see regularly in the emergency department. They're all at risk for nutritional deficiencies. They can have low magnesium, they have dietary issues, they can have vitamin D deficiencies, and they can have hypocalcemia as well. There are also some like unclear mechanisms of PTH suppression in these patients, so they're also at risk. And then when you have your volume overloaded patients, people with CHF, your hypertensive patients, think about whether or not they're on loop diuretics. So Lasix, which we commonly see, will increase your calcium excretion, and so these patients are also at risk. And then there's a bunch of other ones. So one is massive transfusion. We know that there's a lot of citrate in blood products that help with anticoagulation. And this citrate, which we mentioned before, some of your calcium is bound to anions, and citrate is one of them. And so you can have clinically significant drops in your calcium. And because of that rapid drop to hypocalcemia, you can have these patients be symptomatic as well. Younger patients that are in rhabdo can have phosphate overload leading to hypocalcemia. You have all your congenital disorders, so the Tourette syndrome. Patients in sepsis, shock can have hypocalcemia. Unclear mechanisms, but there's a lot of like metabolic things going on. Your patients with pancreatitis as well, because they get precipitation of calcium soaks. And then obviously post-surgical, so any kind of thyroid surgery, parathyroid surgery, you should be thinking about hypocalcemia. Okay, so numbers, don't have to memorize anything, but just roughly know that less than 6.5 is super low. 7.5, less than that is low, but not necessarily dangerously low. But also keep in mind that acute drops will have more significant effects than someone that's chronically low over time. And then in terms of symptoms, again, going back to what we talked about with action potentials. So patients with hypocalcemia, they're not good at contracting. They have a lot of neuromuscular irritability. They'll have paresthesias in their mouth, their fingertips. They'll have cramps. They'll feel generalized weakness. You have the fun signs, Chopstick and Trousseau, which we don't necessarily check for in the ED. And then think about neurological symptoms. They'll be a little bit non-specific, confusion. Sometimes these patients will hallucinate, but importantly, if you start to see seizures, that's a dangerously low calcium. And then cardiac dysrhythmias, which I'll talk about briefly. The EKG changes for hypocalcemia. Pretty easy to at least quickly commit to your head. Just think about the QTC, the QT interval. When your calcium is low, you're going to have prolonged QT. And so these patients, when you look at their EKGs, they'll have QTCs that are prolonged. Primarily, you'll see the ST length. It will be the part that's increased. And you really only see that in hypothermia and hypocalcemia for the most part. And so that should be something that clues you in. And the rest of the EKG will often look pretty normal. So the T waves will look basically unchanged. These patients don't tend to go into dysrhythmias as commonly as in hypokalemia or hypomagnesemia, but you should still keep in mind that they can go into torsades as well. Another EKG, this is hypocalcemia. This patient had DeGeorge syndrome and had a serum calcium of 5.2. And again, prolonged QTC is what you're looking for here. And then in terms of management. So management, really quickly, I'll talk about, depends on how your patient looks, as usual in the emergency department. So if you have a patient that's asymptomatic, you're working them up, maybe this was a young guy that you thought was in rhabdo, he ended up giving him some fluids, you look at his calcium level, it's a little low. It's greater than, it's 7.5 or a little bit greater than 7.5, but still in the low range. And this is someone that you're thinking about sending home with close follow-up. You can send these patients home with just PO vitamin D and oral calcium in the carbonate or citrate form with close follow-up as well. And then if your patient is symptomatic, so that means they're having those signs of neuromuscular irritability, they're having a seizure, their PT is prolonged, then you're going to switch to your IV calcium. And we know we have that as gluconate and we have it as chloride. You do first 1 to 2 grams of either of those. We know we prefer gluconate because of the kind of old, not old, but like the thought process that the chloride can extravasate and cause localized tissue damage. You do want to give first that 1 to 2 grams and then a slow infusion because the effect that you get from the initial kind of push of calcium is limited to a few hours. And then these patients will obviously get admitted. When you're doing calcium infusions, there is a teaching to do a rate between 10 to 20 minutes of that infusion because there are cases of patients that have gone into systolic arrest if the rate of infusion is faster than that. And then I'm not going to really go into this, but Stone Heart, we have these cases from the 1930s that are not super high quality evidence, but in patients with digoxin use, which we don't see regularly anymore. Something to think about is treating varied electrolyte abnormalities, especially calcium, potassium, because of this potential risk of ditch toxicity. Okay, and then you're going to also look at the rest of the electrolytes. If they have hypercalcemia, make sure you're paying attention to magnesium and repeating that as needed. Okay, so let's talk about the highs really quickly. Hypercalcemia are going in the opposite direction. What are you looking for these patients? You're looking for patients with a goiter, patients that look like they may have thyroid disease on your clinical exam, patients with hyperparathyroidism, either they tell you or you're investigating a little bit further and say that they have some risk factors for that. Patients with malignancies, because they can get bony mets, bony lesions that can result in hypercalcemia. And then plenty of other stuff, still thinking about your renal disease patients, thinking about patients that are getting frequent transfusions, patients undergoing, and then patients with hypertension because they can be on thiazide diuretics, which we see pretty commonly. We know that these can cause calcium excretion to be diminished, and you can have hypercalcemia in these patients as well. So some numbers again, pretty high is greater than 14, high greater than 12. Again, not like hard and fast rules, and nothing to memorize, but just numbers to kind of look out for if you're already concerned with calcium. And so in terms of the symptoms, I won't spend a ton of time on this, but we all remember the mnemonics from medical school, your stones, bones, groans, psychiatric overtones. These patients will have all of these symptoms, or some of these symptoms, maybe none of these symptoms, but they can be confused, they can have renal stones, they'll have bone pain, bone destruction, abdominal pain, vomiting, they can look pretty sick, pancreatitis, and renal insufficiency as well. And then in terms of your EKG, again, kind of focusing on the QTC. So these patients with hypercalcemia will have a shortened QT, short QT. But another important thing that kind of came up while I was looking at these EKGs is that J wave. And so here I have quickly, we know that our J point is kind of the standard point on your EKG that tells you the end of your QRS. And the J wave is this upward positive deflection you can have at that point, which we typically associate with hypothermia, but it's not pathognomonic for that. You can also see it in hypercalcemia, and you can also see it as a normal variant, which is kind of as with many things, EKG. And then, like I mentioned in my initial case, we have these instances. There are actually a good amount of case reports that show this ST elevation that you can get that mimics a MI, and it's really just an artifact because of the shortened interval between the S wave and the end of the T wave. And in these patients, if you correct the calcium, their EKG is normalized. So just a quick couple of EKGs. This is a 33-year-old man that came in with like altered mental status and a lot of weight loss recently. This EKG popped up and they thought, oh, maybe he's hypothermic. They got his temperature, he was normothermic. They got his blood work and they saw that his serum calcium level was 16.3. He was found to have a parathyroid adenoma. And once they treated his calcium, his EKG also normalized. And here the arrows are kind of pointing to that same kind of J wave. More EKGs. This guy, another 41-year-old guy that came in, actually this was super sick. They took this EKG. He went into VFib arrest almost immediately after they took this EKG. They were not able to resuscitate him. But when they got his blood work that they sent off before he arrested, his serum calcium was 24. Obviously, this guy was super sick, and you can see on the EKG that kind of same kind of presentation with these J waves. But just a very like classic EKG to look out for, and then of course that very short QT as well. And then the same thing, short QT, hypercalcemia. I don't have a fun story for this one. All right, so treatment. A lot of the treatment or management for hypercalcemia I got from this great paper I found by Dr. Gertheimer and Dr. Sinner that they wrote about managing hypercalcemia actually in the elderly population. And this was from 2013, but a lot of it still rings true. Your first kind of mainstay is going to be fluid resuscitation. But you do have to tailor that based on your patient's fluid status. So obviously your patients that have CHF, that have renal disease, you're going to have to be a little bit more careful about flooding these patients with fluid. You have other options as well. You can use bisphosphonates. These are especially great in patients with malignancies. And because it acts on bone resorption and inhibiting that process, and these patients tend to have hypercalcemia secondary to their bony disease. You do have to dose these patients for renal disease as well. The medications you can use are zoledronic acid and pomidronate. And these medications you have in the IV formulation, you typically admit these patients for that management. We have calcitonin, which we had briefly talked about before, which increases your urinary excretion of calcium. And you can actually give this because it works pretty quickly. Rapid onset in 4 to 6 hours, although it doesn't last for very long. But it can be a good tool to utilize to help reduce hypercalcemia patients in a short period of time. And then some other ones, glucocorticoids. I didn't do too much research into why this works, but I know that it works really well in patients that have hypercalcemia secondary to excessive vitamin D intake, or from the overproduction of calcitriol and other steroids. And these can be useful in patients with Hodgkin's lymphoma or with multiple myeloma. You usually give a dose of 40 milligrams daily for prednisone, if you're going to go down this route for treatment. And then there are a couple other ones. There's, I don't know how to say this, Calcept. This drug, it's kind of weird. It actually mimics calcium to your parathyroid. And so your parathyroid senses that there's high calcium, and then in response to that does the opposite. And basically kind of pushes your body in the other direction to reduce serum calcium levels. And so these work really well in patients that have parathyroid carcinomas. And then finally, dialysis is an option. You can do hemodialysis with no calcium in the dialysis fluid. And this can be used in patients with severe hypercalcemia that's resistant to the other therapies that we talked about. And especially patients with extremely elevated calcium levels of greater than 18 that are having neurological symptoms. Okay, so a quick recap. In terms of hypocalcemia, metabolic emergencies in the emergency department, pearls to take away, use your eyeballs, look at these patients and think about what their risk factors are based on your history and physical exam, bone things, kidney things, malnutrition, GI. Keep that in the back of your mind in terms of evaluating your patient. For workup, easy, right? You get your shock panel, you get your BMP, you correct for albumin if needed, and then think about what are their clinical history and their calcium level fits with the presentation. For the EKG, like I said, it's all about the QT. Hypocalcemia, look for a prolonged QT, and hypercalcemia, look for a short QT, and also your J waves. And then in terms of treatment, when it's low, you can supplement either PO based on their symptoms or IV. When it's high, you think about your fluids and you think about all of those adjuncts that we just went over. And then in terms of your dispo, as always in the emergency department, if your patient is asymptomatic, is pretty healthy, you have to follow up, and the calcium level is not extremely deranged, you consider discharging these patients with PO interventions. If your patient is super sick, if your patient is a little bit sick and they have a very extremely low or extremely high calcium level, then you want to think back to your history, try to come up with a reason and explanation for why they have this derangement, and then you want to admit these patients for further monitoring because it can have very devastating outcomes. Awesome! Questions, comments, feedbacks?
I love your energy. That's wonderful. I wish I had your energy. That was wonderful. A couple of just quick comments.
Yeah.
One is, when you're talking about hypercalcemia and you're doing the calculation, when you're saying what is high and what is low, especially what is low, remember you have to take into account albumin.
Yes.
Because you're worried about ionized calcium, but when you drop your albumin, you lose really the unionized, which doesn't protect you. So you want to remember that. Usually for about one drop in the albumin, you'll lose something like 0.04 to 0.8 of the unionized, but that won't hurt you. So you can calculate that back. And you can get a VBG and ask for ionized calcium, which will help you, as well as doing things like, looking for tetany, Schwarzschild sign, Trousseau sign, that can help you how symptomatic they are, looking at the EKG. The other thing is when you're treating it, the hypocalcemia, you can use either gluconate or calcium. Just remember, if you're going to use calcium chloride, you can use calcium gluconate or calcium chloride, make sure your line is really good. Because calcium chloride, even though there are some people only give it in a CVP, I've given it peripherally, but it has to be a line that won't infiltrate. If the chloride infiltrates, it's very, very caustic. Gluconate is safer if you're not sure about your line. And for each gram of calcium chloride you get about 3 grams worth of calcium gluconate. That's what, for example, with hyperkalemia, you can decide on the doses when you're using that. For the hypercalcemia, these people will come in, especially the elderly. Often they have a malignant underlying cause like myeloma or METs. And they'll come in very lethargic, changing mental status, and looking very dry because you lose sodium and water and keep in the calcium when you're hypercalcemic. So you really want to hydrate them well, cautiously. You don't want to put them into fluoride failure, but you want to hydrate them well with sodium chloride. And then if they're well hydrated, some people, there's some controversy, some people will then give Lasix. And then what you should do, though, is once you've started your resuscitation with fluid, it's called endocrine. They're very high. And they can decide if they want to use bisphonates, or they want to use calcitonin, or they want to use others.
Awesome. Thank you so much, Dr. Gerson.
Yeah. And just a reminder for telemetry for these patients.
Yes, absolutely. Telemetry is very important.
Excellent presentation. This is Shadi Ozatopshi, and especially great choice of cases. You get extra points. But particularly for the juniors, a good way of remembering the symptoms, signs and symptoms of hypo or hypercalcemia is understanding the pathophysiology, as you explained. Remember that calcium is the gatekeeper for sodium chloride channels. And in order for the cell action potential to start, you need the ion exchange through this channel. If you don't have enough gatekeeper, if there's not enough calcium, any small ion exchange can start the action potential. So you have all the signs of hyperstimulation. You have diarrhea, increased acid secretion, and peptic ulcer disease. You get cardiac arrhythmias, you get seizures, because there's not enough calcium to block the channel, and any simple ion exchange can stimulate the cells. But if you have too much calcium, then action potential is delayed and not enough stimulation happens. So you have depression, you have weakness, you have constipation. So the symptoms go well with pathophysiology, and you have to, when you have a patient with multiple organ complaints, you can put them together. A lot of time you can find a electrolyte imbalance that can explain all the findings. Thanks again for the excellent lecture.
I'll make a quick comment about telemonitoring, as Sophia mentioned. I don't think it's a bad idea, but I will say that Howard Levitt, the previous chair of cardiology, gave a lecture a couple years ago about telemonitoring, and he said that it's not indicated for electrolyte. It's never been shown to change.
Oh, good to know.
Use that with how you would. I think it's probably institutionally dependent.
Great, thank you.